Good afternoon everyone, and thank you for coming along today. You're very welcome. My name is Neha Sethi and I am a Deputy Director of the Mason Institute, based here at the University of Edinburgh. For those of you who might not be familiar with our roadshow events, basically the Mason Institute is at the forefront of research into the protection and promotion of human health through robust health research regulation. Through a year-long programme of roadshow-style events, the Mason Institute Lunch Series reaches across the boundaries of discipline and institution to directly engage with crucial human health actors. This includes researchers, practitioners, policymakers, patients and the public. And this is all in order to exploit ongoing research and explore the challenges therein. And in this vein, we're absolutely delighted to welcome Dr. Mark Taylor along today. Thank you very much for coming along, Mark.
My pleasure.
Mark's going to be speaking about the commercialisation of tissue and data, and Edward Dove is going to be offering a response, and I'll offer one as well after Mark's talk, and then we'll open up for a broader discussion. If I tried to list everything that Mark's been involved in, we wouldn't have time for a talk. So just to give you a very, very brief introduction, Mark is Deputy Director of the Sheffield Institute of Biotechnology. He's a Senior Lecturer in the School of Law at the University of Sheffield. He specialises in health information law and privacy. He is a mid-career Fellow of the British Academy, Chair of the Confidentiality Advisory Group for the Health Research Authority, a member of Dame Fiona Caldicot's, she's a National Data Guardian, her Independent Information Governance Oversight Panel. So Mark, I'm just going to open it up to you.
Thank you. Thank you very much for the invitation. I'm looking forward to the discussion more than I am hearing what I have to say. So I'll try and get through this bit as quickly as possible. Principally because I think there are lots of questions which we have not yet got clear answers to. So I think what I do is just try and set out my understanding of what some of those questions are. But in a context. I think the context is one in which study after study demonstrates that people are relatively content with the use of health data for research purposes if one is able to demonstrate that the research is for public benefit. If one is able to demonstrate that there are adequate and robust safeguards in relation to the use of the data, safeguards such as anonymisation. If there are penalties for misuse, these are things which are indicators of public confidence and trust in the governance. A contra indicator is disclosure to private companies. So even those who are relatively content with the use of patient information for research purposes seem to have more questions about the governance, be keener on ensuring certain controls are in place when the disclosure is to a private company. So it's not to say that people don't think that this is something that should happen, but it's just an indicator that they are going to be more cautious and they want more reassurance around controls that are going to be applied. This is in a context where we want data to be used and we want things to happen, we want drugs to be developed, we want diagnostic techniques to be improved, we want data analytics services to be available, and a number of these things aren't going to happen unless we engage with private companies. So there's certain things which we do want to see happen to improve care and treatment that rely upon engagement with private companies. But the question is, how do we do that in ways that give people confidence that it's only being done appropriately? Okay. If you look at the public attitude surveys, and you look at the work which has been done that tries to identify what people's concerns are with the use of data, particularly by private companies, people express concerns about misuse. data falling into the quote-unquote wrong hands. People express concerns around profiteering, unfair, disproportionate profits being made by companies using data that wasn't provided for those purposes, particularly if the data is being given for research purposes with a particular kind of altruistic intent. The idea that a company is going to come in and make lots of money off the back of that doesn't sit very easily with people. There's also a concern, which is related but different, about the privatisation, the commercialisation of the health service, and the concerns that the public service ethos of the National Health Service might be undermined if companies are coming in and making money off the back of data and tissue which is being provided during the course of receiving care and treatment. So I think there are concerns related to misuse, there are concerns related to profiteering, there are concerns related to commercialisation. They overlap, and there are probably other concerns as well, but if you look at the things which are spontaneously identified by individuals as concerns they have in relation to the sharing with private companies, these things keep recurring. Okay, so how do we address misuse? I think there we might draw a distinction for the purposes of analysis between misuse that is unlawful and lawful uses that might be considered misuses. So if we look at unlawful uses, particularly if we focus on data here, then one might look at the existing controls. So Section 55 of the Data Protection Act already makes it a criminal offence to obtain, to disclose personal data without the consent of the data controller. If you're successfully convicted of disclosing personal data without the consent of the data controller, you are subject to a fine, £5,000 in a magistrate's court, unlimited in Crown. There have been questions as to whether or not that penalty for obtaining and disclosing is sufficient. There have been calls over the years for the penalty to include the possibility of a custodial sentence. There have been concerns voiced by the ICO in the past about the fact this is a non-recordable offence, and so suggestions that this should be a recordable offence to reflect the gravity of the offence. So there might be things there that we can do that tighten up the existing law around data protection, the existing criminal law around disclosure of data, that would strengthen the rules around misuse. If you look at the most recent report by Nuffield, there's a call, Nuffield Council of Bioethics, which has just issued a report on biological data, health data, and the use thereof. There they call for criminalisation of misuse, deliberate misuse of data. So already we have kind of the rules around disclosure, unlawful disclosure, and they're saying, well, actually now deliberate misuse should also be a criminal offence. So there might be things which we can do that strengthen the existing rules around misuse when that misuse is unlawful. Can we have lawful misuse? Can we have misuse which is authorised? Well, I suggest we probably can. If we can, then we may want to attack that, approach that in a different way. So how might we have misuse that is lawful? Well, things currently fall within a particular regulatory framework if they're identifiable. They fall out with that framework if they're not recognised by the law to be identifiable. So we have certain disclosures of data that are not identifiable, that are not subject to certain rules and regulations because they fall out with that particular regime, both the regime of data protection law and also that of common law duty of confidence. But there have been concerns expressed in relation to the disclosure of non-identifiable data. Most recently we've seen some of the disclosures by the Health and Social Care Information Centre in England and Wales fall under scrutiny because data was being disclosed to organisations, including commercial organisations, that wasn't technically identifiable, so didn't fall within the scope of DPA or common law duty of confidence, but was nevertheless at patient level. And there were concerns over some of the purposes and organisations to whom that data was disclosed. And there were concerns that there weren't the controls over that disclosure. Because the data was not identifiable, the controls that would otherwise have operated just didn't. As a result, the Health and Social Care Act 2012, which is the act which gave the Information Centre additional powers to collect, publish and disseminate information, was amended by the Care Act 2014. The Health and Social Care Information Centre is now under statutory responsibility when it acts to take into account the need to protect and promote individual privacy. It can only disseminate information if that information is for the purposes of the provision, to support the provision of the health and social care service, or the promotion of health. So there may be circumstances where even if data is not identifiable, we can introduce criteria that try to promote the uses of the data that we would consider to be appropriate uses and avoid what we would consider misuses, or at least have been considered by some to be misuses. And this is getting into the territory which I want to discuss with you, because it's not always easy to determine exactly what constitutes a misuse. And I think we can illustrate that if we move, so moving from kind of authorised or lawful uses of non-identifiable data and how that can be a misuse and what we might be able to do and what has been done in a particular context. Turning to look at lawful uses of identifiable data. What controls do we have currently over the use of identifiable data? Well, one of the ways in which we seek to control the use of identifiable data is by ensuring that data is used consistent with individuals' reasonable expectations. One of the ways we do this is by asking people to consent to the use of their data. But can consent itself prevent misuse? Here, an example cited in the Nuffield Bioethics report, taken from the US, I think is a useful example here, where Target, a US retailer, sent out coupons, money off coupons, to a school-age girl, to give her money off baby products. Dad wasn't very happy that his school-age daughter was receiving money off coupons for baby products. Turns out she had need of them. Now, here's an example where we regularly sign up to loyalty cards. Within the consent we give when we sign up, we agree to the use of our data in these particular ways. We receive these money off coupons. When we do so, do we always fully appreciate the potential consequences of having done so? Was that use of the data by Target a misuse? Certainly it wasn't an expected use. When exactly would it be a misuse for a company to provide targeted advertising? Focus groups have consistently demonstrated that there are concerns around being targeted by advertising. Marketing is one of the concerns that people have when it comes to commercial access to data. If you look at the examples people give of what they would consider to be improper uses, then they do talk about insurance. But also, regularly, they talk about being targeted for marketing purposes. I don't think we've clearly worked out yet, particularly when it falls within the context of consentages, when exactly a use of data would constitute a misuse for targeted advertising purposes. So if individuals have particular high blood pressure, should we be sending them particular money off coupons for things which are there? Anyway, so we've got this issue about whether the extent to which consent itself provides an adequate safeguard against misuse of data by companies. And here is a question over the extent to which people really know what they're signing up to, whether they understand the implications. And these are familiar concerns, particularly when associated with what's described as broad consent. So when we're operating particularly within the context of a broad consent, or a consent which is aligned with consent for something else, so I consent to the collection of the data because I want the service, and in order to get the service I consent to a number of other uses as well, which maybe I don't read the terms and conditions closely enough to identify at the time I sign up. In those kind of circumstances, what other controls do we need to operate in the space to protect people from a misuse of their data by commercial companies? How, in relation to the commercial access to data, do we ensure that public confidence is maintained? And I think that question is a question which applies to non-consented use, for reasons that were previously given. I think it applies to consented use as well to some extent, and even to the use of data in non-identifiable form. How are we going to take that term, promoting public confidence, apply it in the context of commercial access, and ensure that we are only going to be supporting uses that the individuals whose data is used would recognise as appropriate and not considered to be misuses? Okay, this is where I'm looking forward to the discussion, because I want to hear what you think we should be doing in this space. But speaking for myself, CAG itself hasn't, these regulations haven't been laid yet, CAG itself hasn't taken a view. But for myself, as I'm thinking about these things, I'm thinking that we need to move toward a position where at least 3 things are done. I'm going to label those things expect, respect and accept, just because era is easy for me to remember. Expect, I think we have to move towards a position where we are confident that people are expecting data to be used in particular ways. Whether that's by a private company or not, it's the purpose for which the data is used. I think we need to ensure that people are aware of. And for years, data in the NHS has been used in ways that people haven't expected. They haven't realised that data is used for audit purposes, for survey work. They've just assumed that the data is there for their care and treatment, and see no reason why identifiable data would need to be accessed by anybody that's not treating them. Now, that has happened for years, for good reason, but people haven't been aware of that. We're now trying to make people aware of that broader use of their data at the same time as other actors are entering the space. And this is making people feel particularly uncertain, because they feel now that private companies are coming in and doing things with their data, providing data analytics services to clinical commission groups that are entirely new activities. They're not new activities, it's just that they weren't aware that they were happening previously anyway. So, raising expectation. It's a challenge, but we have to meet it. Respect. Once we are clearer with people and people will better understand exactly how their data is used, then we should respect the individual choice to opt out of a particular use in all but the most exceptional circumstances. That's a basic requirement for respect for persons. We're not going to be able to design a system where the default is exactly what reflects everybody's individual preference, because people have different individual preferences and we can't design a system that has a default that anticipates that. But we should be able to design a system that respects individual preferences, and that means changes to the number of infrastructural systems to allow particular preferences expressed in one place to be followed through and actioned in another. Given the lack of interoperability within the NHS, that's a challenge in itself. So moves to raise expectations, moves to respect individual objection, and accept. We have to try and move to a position where data is only used for purposes that individuals, the individuals whose data is at stake, and tissue is at stake, we're talking about tissue as well, is only being used for purposes that they themselves have reason to accept. Even if they haven't themselves accepted it through explicit prospective consent, one should be able to explain the use in terms that explain why they themselves have reason to accept that use. And I think that ties to an idea of public interest. So it doesn't see public interest as some aggregated utilitarian kind of model, but sees individual interests as what we're trying to protect from protect public interest. So, I think we do need to tackle this issue of private companies' access to data and tissue. I think we need to do it by being honest about the fact that we need them to have access in some circumstances, but we need to be clear about what the principles and processes are that will protect persons in ways that ensure only appropriate access. How do we do that? Well, so far I've only talked about misuse. There are various things we might be able to do misuse. I haven't talked about profiteering and commercialisation, but there are different, I think, approaches which would need to be taken there. But in each case, I think these principles of expect, respect and accept are guiding principles which should help take us to a place where the only use and the only commercial use of data is that which patients would recognise as appropriate.
I'm just going to speak very, well, as brief as I can make it. I guess I wanted to share with you some thoughts from the recent Nuffield report that you mentioned, and how I think some elements of that should be central to how we tackle these challenges moving forward. And also to just touch upon some of the work that Graham and I have done under the auspices of the Scottish Health Informatics programme in developing a good governance framework. So I'm sorry, I know you might have heard some of this before because we just had a workshop in Sheffield. So the Nuffield report, which was out earlier this month, made several recommendations which I think are very important here. First of all, the report stresses that there's a strong public interest in the responsible use of data in research to support the development of knowledge and innovation intended to improve the well-being of all by enabling advances in healthcare. So outright, we have an acknowledgement that using data in appropriate contexts is important and in the public interest. But we also have explicit reference to innovation and the fact that this is inextricably linked to necessary commercial access. This has also been bolstered, this idea of public interest and this promotion of sharing has been bolstered by the 7th Caldecott principle, which argues that the duty to share data can be as important as the duty to withhold information. And most recently, Mark mentioned the CARE Act 2014, and within section 111, subsection 2, the Act introduces a legal obligation to actively encourage and facilitate safe and ethical research. So I think it's encouraging that the landscape is slowly changing, and it's great to see this active encouragement of sharing. And at the same time, we know, as Mark's mentioned, there are lots of issues around who is accessing data and for which purposes. Now, the report also stresses the importance of public engagement. It's a very strong theme that emerges through the entire report. And this is based on two clear reasons. Firstly, that public attitudes can vary greatly between different individuals, between different groups, around what uses may be deemed acceptable or unacceptable, what may be reasonable or unreasonable uses. And the extent of benefit or harm that can arise out of certain uses. People feel very differently about this. Some can oppose certain uses vehemently and others can be indifferent. This leads on to a second point, which is a call for a greater evidence base, so greater exploration into public attitudes around uses. The report also advocates a principled approach towards any kind of governance models. And there are 4 key principles in that approach, namely the principle of respect for persons, the principle of respect for established human rights, the principle of participation of those with morally relevant interests, and the principle of accounting for decisions. And from a governance perspective, I think that the design of any good governance approach and in tackling these questions that you've raised, it's necessary to rely on these 4 principles, and I think they're a very good basis for kind of moving forward. I think there's another point that kind of Graham and I kind of came to understand with our work in SHIP, which was that in order to ensure that citizens' records are accessed and used in ways which are publicly acceptable and socially and ethically defensible, and that can legitimately be claimed to demonstrate good governance, it is essential that public opinions, values and concerns are addressed in the design of governance from an early stage. And this is something that can be demonstrated from our good governance framework with the Scottish Health Informatics programme. So those of you who aren't familiar with SHIP, it was a Scotland-wide research programme involving universities in partnership with the NHS Scotland. And it was set up to improve the collection, management and analysis of electronic patient records for health research purposes. Graham and I engaged with different stakeholders from the outset, with people in the NHS, Caldecott Guardians, health researchers as well, who'd experienced in the challenges of using data sets. And a key output of the research was that we developed a template for assessing what might count as good governance. We worked with public engagement colleagues, and they ran focus groups where they sounded out the different elements of governance that we had proposed. And so we were able to refine our good governance framework and explicitly fold in public concerns. And I think that's an important kind of procedural model that you might want to think about. A question that kept appearing was, as you've raised, what constitutes an acceptable balance of individual rights and public interests in any particular context? And the role of public engagement exercises here are particularly valuable in terms of helping us to explore public understandings and expectations of privacy and public interest, including commercial access to the data. These can not only inform policies and decision makers about broadly acceptable or unacceptable uses of data, but they can also help to guide governance design by indicating, for example, particular preferences or aversions of particular governance approaches. It also reveals the different levels of understandings about the kinds of public interest that are at stake. And this might actually lead to necessitating further engagement with publics. And awareness-raising campaigns as well. You've talked about expectations and the importance of dialogue and awareness-raising. Just to offer you some insights into the findings of our focus group work, on the issue of consent, there was a strong preference for consent, for the need to be asked about how data was going to be used, but there wasn't unanimous agreement on what kind of consent was required or what consent might look like. There was actually acknowledgement of the challenges that come with obtaining consent, the impracticalities, appreciation of the fact that it can impede research, that it may not always be the only or the most appropriate mechanism in order to safeguard uses and determine appropriate uses. And we explored a range of alternative mechanisms through which members of the public might be given control over their data, including greater public representation in governance processes and involvement in decision making around how data are used, as well as greater transparency and openness about data use. And I think this all is reflected in your ERA model. So the lesson we learned for consent is that consent can't be dispensed with lightly, and it requires evidence that expectations around consent are taken seriously, even if they cannot always be met. So in terms of SHIP, we developed our good governance framework and we developed a statement of guiding principles. And the principle on consent actually reads, personal data must not be used without consent unless absolutely necessary. Where obtaining consent is not possible or practicable, then anonymisation of data should occur as soon as is reasonably practicable, and/or authorization from an appropriate oversight body or research ethics committee should be obtained. So it's not this either-or, consent or anonymised, but we're also exploring authorization, and it's this hybrid of looking at all the different models that might actually help us achieve good governance. Just kind of to end, another key aspect of our work with the publics was this idea of risk. Risk was very important, different types of risk and performing risk assessments. And we tried to embed a risk-based approach to reviewing data access applications within our good governance framework as well. And again, as I said, these three mechanisms aren't mutually exclusive. I want to give Ted a chance to talk as well. So to kind of reiterate, I think that within your ERA model, you mentioned respect and this idea that people should be allowed to opt out, but I think that another necessary aspect of respect is actually, it can only come out of engaging with the public in terms of understanding the spectrum of concerns that they might have. And I think that will lead to greater acceptance and reasonable expectation. Okay, thank you.
Hopefully there's time to talk about some of these following responses. I think the notion of public engagement is quite interesting, and that I think should be unpacked a bit more as we apply it to this particular theme, so hopefully I can speak quickly. I typed up some notes, so I will do not the stand-up or extemporaneous presentation. I don't have those skills, so I will be reading from something I typed up. And this is a nice follow-on to a workshop that Mark hosted on January 30th on the same theme, so it's nice to see this development, which is absolutely critical. I think commercial use of health data is worth discussing and debating because we know that it remains relatively unexplored by scholars, yet is of high concern to the public. We don't need to look any further than the front pages of The Guardian or The Telegraph public opinion polling or some of the highly accessed blogs to know that that's the case. I think Dr. Taylor is quite right in my view that, broadly speaking, the public are more cautious about health data sharing for use by private companies. As he says, there is some evidence that points to a link between public confidence in the governance of health data protection and the mechanisms by which companies can access and use health data. But what are we to make of this point? My own concern prior to this talk was a lack of clarity around this issue, a lack of clarity that is our own failing in the academic community. This reflects a failure, most principally, in asking the necessary questions. We cannot begin to address concerns and validate those concerns and offer solutions and validate those solutions about commercial access to or use of data until we unpack the meaning of commercial access or use and data. To put it crudely, my concern was that an employer is not an insurance provider, is not a drug manufacturer, is not a search engine provider. Nor are any two companies within these varying types the same. In a recent paper co-authored by Dr. Taylor, Life Sciences, Society and Policy, the point is made that there are difficulties in distinguishing between commercial and non-commercial research in the health sector. Indeed, bunching these entities under one umbrella of commercial does not help the matter, and likely does not accurately reflect the veritable underlying nuance concerns of the public. Additionally, of course, there are various meanings of access and use, and the word data itself is subject to varying interpretation. Data, which comes from the Latin word dare, meaning to give, which is ironic because they're actually taken, I would claim are socially constructed phenomena. They are inherently incomplete and selective precisely because they are abstractions of phenomena. They're chosen, measured, recorded, and interpreted in some way by some agent. They possess materiality, they themselves have become a liquid commodity, and they are a symbol of varying cultural meaning. That makes it quite possible for injustices to be embedded in the data itself, separate from any access or use by an agent. In short, my concern was, and to some extent still is, that abstract concerns labeled against abstract entities cannot lead to practical solutions. Each company, each data set, each purpose and process for access and use pose different issues. So addressing commercial access to and use of health data, holus bolus, is nothing short of a Sisyphean task. Until we first put each of these terms under the microscope to accurately source the problem, we cannot proceed to develop credible answers. But Dr. Taylor has assuaged some of my concern. His taxonomy of concerns, misuse of privacy, misuse such as privacy intrusion, profiteering, so exclusive private benefit without public benefit, commercialization, so corruption of the public service ethos of an organization, is novel and useful because it helps clarify what would otherwise remain vague, abstract qualms expressed by a phantom public. It also helps point to paths of remedy. But let us reflect on the driving question Dr. Taylor has posed and addressed this afternoon. If we share a common aim to safeguard public confidence in appropriate use of health data, how might we address each of these concerns, of which we heard about? One, misuse, but also profiteering and commercialization. I recognize the value of this trifle characterization of the concerns, if only because I trust the evidence proffered by Dr. Taylor, absent my own independent verification. But I believe we can effectively address only those concerns related to the first, which I'm glad he discussed, that of misuse. And if we can effectively address the first, the other two become superfluous. We cannot avoid profiteering or perception thereof, nor can we avoid exclusive private benefit. The reasons I propose are because avoidance is undesirable, and avoidance is an impossibility anyway. We must avoid avoidance and instead seek mitigative practices. The primary concern, it seems to me, and here in the evidence, is a perceived or real fear of misuse through data. The fear rests on use of data in a non-transparent and unaccountable way. This fear, though, transcends the commercial space and can permeate all sectors, including government and the non-profit. All the more reason then why imposing sector-specific controls, in this case on the profit-seeking sector, will not deliver good data governance, especially if those controls are imposed through law or regulation, and that's my point. Any approach that regulates access to commercial organizations or for commercial use per se is suboptimal because regulation will not in itself promote the conditions necessary and sufficient for public confidence. Indeed, my claim is regular controls may in fact diminish it. Let me propose that instead of looking to law, we look to ethics and in particular virtues. Good data governance, a system that protects and promotes the responsible stewardship of data, must be expressed through trustworthiness. In other words, the identification and realization of the conditions foundational to establish and maintaining trust in another person, in a system, or in a practice. Trustworthiness is ultimately, I believe, the approach we need to promote public trust and confidence in systems that can and should allow for commercial access to and use of health data. So how might we work towards good data governance that mitigates but does not avoid the potential for misuse of health data? Some might say, and we heard, a pseudopath is instituting some option of individual opt-out, providing more information about what is done with health data, in other words, the purposes and agents behind access and use, and forming an independent watchdog or independent review group capable of protecting individual and public interests. These are all sensible options to me, though I'm not sure they constitute the elements necessary to establish and maintain trustworthiness. Let me instead mention one, in the time remaining, foundational condition to trustworthiness, a condition that must simply be designed correctly: transparency. Let me be clear, transparency cannot be instantiated simply through unidirectional information dissemination. This is not transparency. Transparency is about creating the capacity for the availability, accessibility, and comprehensibility of information which may be communicated across a network from node to node. A transparent system is one that allows for clear and honest communication of information to people such that they can ascertain and understand the state of affairs in a given situation and predict how their actions and actions of others will affect those affairs, and that does not unnecessarily complicate those affairs. In the case at hand, any data initiative or data sharing system that wants to establish and maintain the public's trust must be willing and able to explain what data are being held, what security controls are imposed on them, with whom these data are being shared, and why, all reinforced with proper evidence. Again, this must be expressed openly and clearly. Moreover, any data initiative and data sharing system that wants to hold the public trust must be willing and able to listen to, deliberate on, and respond to the questions and comments posed by publics, and potentially incorporate their input on a meta-governance level. This, of course, is linked to two attributes. Participation and accountability deserve clarification. Participation by publics and agential and systemic accountability, in my mind, are not standalone conditions to trustworthiness, but they are often attributes of it. And certainly transparency is a necessary, albeit not sufficient, condition for participation and accountability. A transparent system is one that enables participation in decision-making, allowing those whose data are collected and shared to exert some non-de minimis degree of influence on data sharing design and activities. To emphasize, without transparency, participation in any system is ineffective. Participation rights necessitate transparency obligations. Where a system of accountability is instituted, it must be accompanied by a transparency obligation on the person or organization holding itself to account. Systems of accountability cannot be too complex to be understood and cannot be designed to undermine the very purpose they set out to achieve, which is to instill confidence that those who have authority and perform actions will assign responsibility unto themselves and hold themselves to monitoring, judgment, and account, with meaningful consequences for failure to perform those actions as reasonably expected. Accountability in any data initiative or data sharing system that wants to establish and maintain the public's trust must be understandable and must be traceable, which is in fact an attribute of transparency. In other words, we must be able to follow the lines of responsibility throughout the course of data flow, in whose hands it has been placed and in whose hands it will be placed, and those agents involved in the flow must be able to explain and justify their conduct at all times before a forum that can pose questions and pass judgment and impose consequences on those agents. Trust takes a long time to be earned and a short time to be lost. Repeated demonstration of transparency, and within it honesty and reliability, is foundational to establishing that data initiatives and systems are trustworthy. Profit, even excessive profit, whatever that means, commercialization and public interest are not incompatible. Opacity and public interest are. This is why I'm skeptical of a fixation on legal solutions. Law makes no scruples about the necessity of transparency for securing the public trust. Indeed, legal scholarship has shown the benefits associated with some opaque and insulated regulatory structures, including the ability to regulate unfettered by partisan politics and majoritarian preferences. We cannot trust the law to effectively address concerns of data misuse. Law can too easily turn towards concern about bad participation, such as political posturing and inflexibility in policy decisions, and bad accountability, such as allowing concentrated interest to monitor the actions of the decision maker and thus look towards regulatory solutions of opacity instead. Operating in a black box is no way to establish trustworthiness. Ethics makes no such claim, however. It values solutions focused on fostering virtuous behavior and will view opacity as a disadvantage and transparency as an unalloyed good. In conclusion, to effectively address the concerns Dr. Taylor has identified, we must rephrase part of his question. The common aim is not so much to safeguard public confidence in appropriate use of health data. Rather, the common aim is to establish the conditions of trustworthiness in those that access and use these data, no matter the sector. By instituting effective transparency through policy and conduct, we show that we are trustworthy. This allows others to trust us, which in turn allows us to access and use health data for the public benefit, however so defined in the agora.